another great friend of mine, Dr. Matt Willis from Marin County, California. So what we're doing here today, and we can take a seat. I'll give a formal introduction to. I'll kind of read off a little bit about Dr. Bhattacharya and Dr. Willis, and we'll get into our conversation. So, first of all, Dr. Matt Willis from San Rafael, California. Dr. Willis is a public health officer from Marin County, California since 2013. He's a physician, epidemiologist, and he's got his medical degree from Temple University, master's in internal medicine and public health from Harvard. Prior to his current role, he was the director of primary care on the Navajo Indian Reservation in Arizona at the CDC, where he led outbreak investigations in U.S. and abroad. Marin County achieves among some of the lowest COVID-19 mortality rates in the country, and Matt, or Dr. Willis, attributes that to his community-centered approach to dealing with the pandemic. So, again, Dr. Matt Willis.
You're here. Wonderful.
And Dr. J. Bhattacharya. Many of you may know of him. He shows up on TV once in a while. I don't know how that works, but he's a professor of medicine at Stanford University. He's a research associate at the National Bureau of Economics Research. He's also a senior fellow at the Stanford Institute for Economics Policy Research. He directs the Stanford Center for on the demography of health and aging, and his research focuses on the economics of health care around the world, and with a particular emphasis on the health and well-being of vulnerable populations. Jay holds an MD and a PhD in economics from Stanford University, and he is the co-author of the Great Barrington Declaration. So,
You're here.
So a couple of things that I said, a couple of things that really stand out for me when it comes to the pandemic and the pandemic response, and how this turned into probably one of the most contentious issues of our lifetimes. And most of that, in my opinion, stems from the lack of communication. Anybody who knows about the work that I do, or anybody who's been with Braver Angels for any amount of time, knows that when the conversation breaks down, tempers begin to flare, people start to make bad decisions, people start to say things that they might not otherwise say, do things that they might not otherwise do. So we need to really promote the conversation. Today's presentation is not to rehash everything that was done wrong, or what we perceive as being done wrong during the pandemic response. We've all been dealing with that Monday morning quarterback mess for the last 4 years. What I want to do with the Truth and Trust Project here at Braver Angels is really start to focus on how we better deal with the next pandemic, because we all know there will be another pandemic. We have to have things that we can do as a society, as us out in the general public, and those that are appointed to represent us in the public health establishment.
Amen.
That conversation has to happen. And so we're not here today to debate the science. We're not here to rehash a lot of what happened, though I'm certain it will come up. It has to. But what we are here to talk about is, how do we have a better conversation moving forward? How do we have a conversation today about how to better debate the science the next time, because there will be a next time. Okay? With that being said, I just want to make sure that everybody, I don't know how many people in this room, this is their first Braver Angels event, but a couple of things that we really want to stress the importance of as Braver Angels, right? It's that we all want to be able to speak freely, fully, and without fear. We want to be able to state our opinions freely, fully, and without fear. We want to treat those that we disagree with respect. We want to welcome everybody to engage And there will be a point at the end of this presentation, or probably about when we get into the 45 minutes, 1 hour mark, where we are going to open it up to conversations for our guests. You know, the engagement and the, you know, encouraging everybody to have their voice heard and really be able to be part of that conversation. Disagree accurately, you know, that's one of these things that so often we see in the media and with our politicians and stuff like that, these exaggerated and ugly circumstances that are just crazy in a lot of ways. But we want to be able to disagree accurately, find ways to work together instead of shouting at each other. Both sides share and learn from each other. And then we're not here to make this be about teaching the other side our point of view or forcing our point of view on somebody else, but otherwise, you know, to just bring our point to the table and instead of trying to prove somebody else wrong. So you know, that's one of these things. So I really appreciate your time and appreciate our guests, Dr. Willis and Dr. Bhattacharya, for being here today. Just for the sake of making this easy, am I okay to call you Matt and call you Jay? Is that all right?
Please.
Okay.
Yes.
All right. I've had several conversations with these guys, and I don't want to. I want to get that out of the way right away because I'd probably screw it up if I didn't. So with that being said, so Dr. Willis, we'll start off with you and as the public health director, Marin County, California. Talk, you know, start off by telling a little bit about, you know, your experience and what you were presented with right from the beginning. So we're just going to lay the groundwork. What were you presented with as the public health director in Marin County right at the beginning of the pandemic?
Thank you, Wilk. It's an honor to be here today. I love Wisconsin. It's been 20 years since I've been here, and I just coming across with this sort of lush and humid weather. You know, we don't get that. We don't get that in California, and it just reminded me. This. Can you hear me better now? Yes. Yeah. So I was just reminded of what an amazing and rich nation that we live in, and I'm excited to join this conversation because I believe that the answer to the question of can we have a better pandemic is an unequivocal yes. And that I think that is a critical question for us to be asking right now. And obviously the question that follows that is how. And I'm also convinced that this is part of that answer to the how. It is going to need to be these kinds of conversations. I think we're actually in I'm both optimistic and hopeful that we're in a good place now coming out of the pandemic where it is far enough behind us in terms of, you know, we need not panic, right? We're okay, but we're also close enough to it to actually have a vivid understanding and memory of what we did and what we didn't do right. So instead of having the kind of conversations I'm seeing happening at the national level where it's just a series of sort of attack and defense, what we really need is this kind of dialogue, and I can't say that I've seen this kind of conversation happening anywhere else. So that is my hope, and the reason that I'm honored and privileged to come to the table. I am not interested in debating Jay Bhattacharya about what Tony Fauci was doing or what Francis Collins was doing. I am not those people. I was not functioning at that level. I think what I bring to this conversation is a practical experience as a local public health officer who is navigating decisions about how to have a better pandemic every day. Those were proximate, practical, poignant decisions that I was facing as a policymaker, as a physician, as an epidemiologist, as a member of the community. And so while, you know, I had that Braver Angels conversation with Francis Collins and some of you, maybe a year or so ago, and I felt like, the high school band teacher who'd been brought to like a to play on stage with Jimi Hendrix, because there's Francis Collins and there's me sort of as public health. But I actually feel like it is important to hear from the perspective of locals, because so much of the pandemic actually did fall on local shoulders. And there was a practical element to the decisions we were making that I think I'd like to add to this conversation. So I'm grateful to be here, and I look forward to this conversation. Thank you.
They're good. Yeah, I appreciate that. And then Jay, I already messed up. That's what I was trying to go with him. But talk a little bit about why you're here, and then a little bit about what you were doing at the beginning of the pandemic, and then where you're at today, and why you think it's important to be here.
First of all, thank you. I'm so grateful to Brave Angels, to each of you that showed up, and especially Matt. I'm really grateful to you. It's been very difficult to get people like you who were responsible for the local management of the pandemic to speak with me. It's been difficult to get national leaders to speak with me, and I think that's part of the problem, and it's what you all at Brave Angels are trying to solve. I agree entirely, 100% with Matt about the possibility of a better pandemic, and I think it starts by these kinds of conversations, by listening to each other, by public health officials from Matt is very modest. He in my view is the best of the Bay Area public health officers, but from the local level all the way up to the top, need to be more open to conversation with people. Public health is a democratic art, not authoritarian art, and a lot of times people, it was hard for people to understand that. It was hard for public health people to understand that. And so the next pandemic requires conversation, requires many minds, and I think that to me is why I agreed to come when Wilk invited me. Wilk and I are now friends, but and he's very easy to be friends with because he's such a sweet man. But it's why I'm so delighted to be able to be friends with people. I think so. Look, you asked me how did I get involved with the pandemic at all? I'm a researcher at Stanford University. I've been studying health policy for most of my career, I've studied infectious disease policy as part of it. My first papers were in HIV policy. I've written on antibiotic resistance, the swine flu pandemic I wrote. So I've been writing as an academic. Very early in the pandemic, I had a hypothesis that given how it was clear the disease was spreading in China and that it had been seeded all over the world already, I had a hypothesis that it spread much more easily than people realized, that it was spreading probably by aerosols through breath. And so when the World Health Organization put out an estimate that 3.5% of people that got infected were going to die very early in the pandemic, I knew that was going to mislead the public, that in fact, many, many more people had already been infected that we didn't know about. That was my hypothesis. For the first time in my life, I wrote an op-ed. I usually just published papers in scientific journals and argued with 3 other people about them, which was someday I'll get back to that. I wrote an op-ed with this hypothesis and calling for a study to measure how many people in Santa Clara County, where I live, had already had the disease through antibodies. And I conducted that study. The results of that study confirmed the hypothesis that 3% of, it turned out by early April 2020, 3% of Santa Clara County had already had COVID and recovered. They had the antibodies. 40% of them had never recalled any experience of any symptoms at all. So it was very clear the disease was spreading asymptomatically with a lot and very easily beyond the ken of public health. And yet public health essentially doubled down on a strategy to suppress the disease down to near zero through lockdown strategies that I knew were going to harm every single poor person on the face of the earth.
Amen.
It's unfortunately it's one of those things where it's hard for me to celebrate that. I mean, the UN put an estimate out that 130 million people are going to starve in April of 2020, and I thought I have to speak up, and that's why I joined the conversation.
Okay. Yeah, and that's what I want to talk about is that conversation piece, because that conversation piece, I think we can all remember back in 2020 when it was 24/7 catastrophizing on the news, right? We had every politician and everybody in the media and everybody, they all became experts overnight on how we were going to deal with this thing, and then we had the 2 weeks to flatten the curve and things like that. But what I really started to have a problem with, and when I put out my video early in 2020, it was horrible, but it's called freedom shaming, right? Stop freedom shaming, because I, as many of you might know, I look through everything through the lens of liberty, and what I saw was not only was people's liberty being stripped from them, but then anybody that tried to speak up about how their liberty was being stripped from them was even stripped further. So that conversation piece was really a problem for me and a lot of the people that I started speaking with at that point. Started having these conversations, and I kept on hearing the same thing over and over and over again. Why can't we speak up? Why can't our voices be heard? Why can we not even share? So Matt, from a public health perspective, because I know you did a lot of community-centered response with your stuff. So tell me about your experience in Marin County and the kinds of input. And I know you actually pushed back against some of those mainstream narratives, whether it be with Governor Newsom or whoever, whatever powers that be. But you took a very pragmatic stance on a lot of these things. So let's keep this centered around the communication aspect of it. Talk about how that communication was working for you and what you saw as a downfall when it comes to that.
Yeah, I mean, to sort of, we heard Jay's early experience, and just to sort of situate where I was at that time, and then why we engaged the community the way we did. This happened very quickly, right? This was a novel. I mean, I put out a public health advisory on January 20th to our community. It was called something. It was a COVID-19. It wasn't COVID-19. It was like SARS. We had, like, for a little while, we actually had a different name for it. I even had trouble finding some of my early documents. And it was just an alert to the medical community that something was happening in China that we should just sort of have on the radar screen. Had no idea what it might be. But when we saw, as you say, Jay, how quickly it was spreading in other human populations, I mean, that's one of the things we sort of, like, people are essentially people, right? The physiology, the virus and the human system are going to behave similarly wherever it goes. So when you look at what's happening in China, you say, why won't that happen here? You sort of recognize that it will, right? So there was already a sense that we needed to do, Wuhan was locked down, like hardcore lockdown. And we had a sense that we needed to do something locally to try and interrupt our course, right? And then Italy was also, overwhelming numbers of cases in northern Italy. Hospitals were being overwhelmed. And we started seeing dribs and drabs of cases in our community. And there was a lot of fear. So that's the position the local health officer lands in, right? This is a pandemic that is spreading very quickly between people across the globe. We are seeing people die. And hospitals in parts of, like, even New York, Italy, are becoming overwhelmed. So far, we're okay in the Bay Area, but that's just because it really hasn't penetrated yet. Our approach, and I think it was echoed in sort of the way we proceeded kind of through the pandemic, was an external one. I think was immediately to say, okay, this is what we're facing. We need to bring together across sectors. We need to bring healthcare providers together. We formed what was called our industry advisors. So we had an industry advisory team where we had 17 different sectors in the community: retail, hospitality, schools, law enforcement, to set a table for a conversation about how shall we proceed in our county to address this threat. I do not think we were exaggerating the level of the threat. I think this was, in fact, a real threat to us as a community, and could easily have overwhelmed our healthcare system because we saw it happening elsewhere. So those were important conversations. I think what I brought to those conversations was a sense that not everyone actually knows the same amount of everything. I wouldn't want to fly a plane. Like, I love that the pilot knows how to fly a plane. I'm not going to run in there and be like, hey, no, I think you should pull on this lever, right? I'm a physician. I'm an epidemiologist. I worked internationally in outbreak investigations. I've published, I mean, I know some things about how to manage a situation like this. It was obviously unprecedented, but many of the cardinal characteristics are things that we understand in terms of disease transmission, herd immunity, et cetera. And so there is a role for expertise in those conversations. And people were in fact looking to me for guidance in very real ways. And so I took that responsibility very seriously. And I think to have some empathy to other public health leadership, I think that was the basic dynamic at that time. It was like, Doc, what should we do? Right? And you're operating in a place of extreme uncertainty. The data is ambiguous. China was like not sharing very much. So like the best laboratory for actually understanding what's happening was controlling the information in ways that were frustrating. And yet you had decisions to make. And I hope just by understanding that as sort of the substrate of what was at play at that time can offer some perspective on why local public health acted in the way they did. We were not getting federal guidance very much. Mm-hmm. We were not, we didn't have the supplies we needed. I mean, we didn't have testing kits. We were literally, like my team was up at night cutting off like the stems on swabs so they would fit into the vials that we need for the viral medium to try and actually get enough tests, because one of the things we needed was data to understand, like Jay says, we needed to understand where this virus was moving. Mm-hmm. But we didn't even have the tools to do that. So when we knew that we didn't have good visibility, we knew that this was a serious and rapidly spreading illness that is overwhelming hospitals elsewhere. And it was in that context that the decision was made to do a circuit breaker, right? And even that, I think, is important. I think the term locked, I mean, if we're talking about trying to sort of have a more healthy dialogue, I think we need to avoid certain terminology. I'm not going to say anti-vax. I think that's a bad term. People who are hesitant about vaccines have lots of reasons for it, and it's a continuum. It's easy for people in public health to just say, oh, they're anti-vax. Lockdown is also, I think, an unhelpful term, because it is not a lockdown. We were very thoughtful about what are the freedoms that people need to be preserved, even in our most restrictive tier. People need to go to the grocery store. They need to go to the bank. They need to go to the doctor, right? So there was this assessment of what is the social harm associated with this measure against the potential risk of illness and death. And those are hard conversations to have, and that's why we needed to have that forum for more community engagement that we built in Marin.
Absolutely, yeah. The community engagement was one thing that was sorely lacking, and you talk about the not receiving a lot of federal guidance, but so many other states, and thankfully in your county you were able to do some certain things, but then we hear in other states that, well, our hands are tied, we're doing this thing. One of the questions, talking about the data and talking about, the things that you've, you were experiencing there, and Jay was talking about the data that he found from the tests that he performed. And this is a question that has bugged me from the beginning of this thing, is how can two different doctors or people, that do this look at the same data and come to a different conclusion? Because I think we saw a lot of that over the pandemic, and one person of great stature in the public health community is looking at data and saying, this is what I'm seeing, so this is what we're going to do. But then another person of equal stature within whether it be academia or the medical field or whatever, looks at that same data, Jay, and comes to a different conclusion and says, no, this is not what we should be doing. We need to be looking at different things. So take a few minutes, Jay, to kind of expand upon that question. How do two professionals look at the same data and come to a different conclusion? And what should we be doing when that conclusion is different?
So the answer is, in science, it's very, very common. In fact, it's the norm for scientists to look at the same data and disagree. It's how science advances. We speak to each other, we have different hypotheses about the same data, and we work out the implications of our hypotheses, then we run another experiment to see who's right and who's wrong, and then we move on to the next disagreement. That's the norm. That's the normal scientific process. What happened during the pandemic was not the normal scientific process. So I wrote that study about Santa Clara County, California, did a very similar study in LA County, California with almost exactly the same result. And the result was death threats against me, attacks on my family, hit pieces in the press about me, attacks within my university, essentially a all-court press to silence me. That is not normal in science. And the problem was that the death risk was exaggerated by the World Health Organization. The implication of the study was that it had already spread much more widely than we'd realized. That meant the death rate, they were putting something called a case fatality rate out, which is an estimate of how many people that had showed up at the hospital or been identified as having COVID. As Matt said, there's very little testing, so it was a very select, very sick population. And then they were telling the public it's 3.5%. The public hears that and says 3.5% of dying if I get it. And it causes panic. It causes fear. And to me, that was irresponsible. Especially when the data that was coming out from my study and then dozens of independent teams all around the world replicating it, finding that the infection fatality rate was much lower than that. Something on the order of 0.2, 0.3, 0.4, 2 out of 1,000, 3 out of 1,000, 4 out of 1,000, depending on how old the population was in the area. The other thing is that the other reason why there was disagreement here is that the question of what to do in a pandemic is not just a medical question. How important is it that your kids actually get to go to school? How important is it that you get to go to church or your mosque or your synagogue? How important is it that you get to play your musical instrument for people that want to hear it? Those are questions that are not in the purview of public health. And public health should not be making those decisions by itself in a dictatorial way, which is essentially the authority that it took on itself. And so when I saw that happening, it was no surprise to me to see the development of resistance within the community to public health. What was surprising to me was to see public health react to that resistance by attempting to suppress it, to demonize people who disagreed with the value judgments of public health, even leaving aside the scientific judgments. And that, I think, was something that we must do better in the next pandemic. Pandemics are democratic in their essence, or rather, pandemic response, well, they're democratic in their essence because everyone's subject to them, but they're also the response to them should also be similarly democratic. Our values are different from each other and may differ very much from a public health officer who's really scared about the disease, or the main thing that they have to control is how many people get infected, but they don't have to worry so much maybe necessarily about, does my kid get to go to school? Do I get to have a funeral for my father? If he's died, if he's dead, can I continue to run my business?
Yeah. Same question, Matt. How do two professionals look at the same data, come to a different conclusion, and then how do you believe? Number one, how do you communicate that? Over the course of your career, how has this been for you, and what do you see this? What did you see at your level?
Yeah, I think in that setting of the all of the uncertainties that we were facing early on, combined with the fear that we were all facing, where I go is data, right? But where I always try to go in those situations is what is objectively true. And it was quite frustrating, actually, to not have clear data available to us. And so I agree with Jay that it is part of the normal scientific process to actually be skeptical of what we might see and debate the findings to find something that's even more refined and more close to truth. One of the problems is that we actually didn't have a very wide range of studies to look to, right? There was very little science coming out. And what we did have was sometimes divergent in the response. So you had your Santa Clara antibodies. There's other studies that were showing other things, right? And so it becomes almost, what a Rorschach test is, where you have the ink blot. And it's really like, I see a butterfly, and I see a bowling alley or whatever it is. And it's about the observer. And I do think there was a certain sort of projection onto this heterogeneity of findings in the data that was reinforcing to the predispositions and the biases of the observer. And what I saw in some of my public health colleagues, because they took it on themselves to sort of see that what we were primarily trying to prevent was transmission, right? I mean, that was kind of the ethos, right? Like the thing you're trying to prevent is transmission of COVID-19. And when that's your view, and then then there's the rhetoric that's invoked around what is the price of a death? Like, what would you do to prevent a death? It becomes a sort of a lens through which people are looking at the data, and they're looking for the things that are most concerning that would validate that approach. And I think that was a problem. And I agree completely with Jay that way of approaching the data leads to a perhaps myopic sense of what public health actually represents, right? And I'm going to be super clear on sort of my definition of public health for this conversation. And it goes back to the World Health Organization definition of health from 1948, which is health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. And I love Dr. Collins. I respect him as much as any other scientist. He made a mistake last year when he said that public health was 100% focused on preventing transmission and 0% focused on any other form of harm. That was not how public health officers were behaving. And I think that's, when we went to open schools, it was with our eyes wide open to the fact that there might be transmission within the school setting, but that was actually at a lower net cost to well-being than school closures. And that was part of the equation.
Thank you. Thank you. And what I really want more of is, because I constantly think, and I'm certainly, nowhere near the public health. That's not what I do. But I want to make sure that the conversations are had, because the conversation is where the course correction happens, right? And there was a lot of course correction needed in whether it be the public health response from a national level or the public health response from a local level in different places. And again, those conversations weren't happening from the several dozen or 100, I don't even know how many conversations I've had at this point, but the one common thing that I continue to hear is, our voices were not being heard, and we needed, whether it be somebody in a local hospital in northern Minnesota who again said that they were closed down for months before they even saw a case, in their town, in their county. And I'm thinking about your definition, or not your definition, but the World Health Organization's definition, of not merely the absence of disease, but mental, physical, all this stuff. And how much was lost, Jay, at some of these, in these rural areas where there wasn't any transmission happening, but those people were not getting the health care that they needed within those hospitals. Okay, so let's switch gears here a little bit, because we're getting close to the end of the hour, and then I want to open it up for questions from the audience. But I want to talk a little bit, Jay, about the ideas presented within the Great Barrington Declaration, not to rehash that so much, but moving forward, the idea of how do we ensure the most vulnerable among us are taken care of, and that there's a whole picture looked at with the next response to the next pandemic, because we clearly have a problem between the public and the public health. And I think the public, especially from my life experience and the experience I have from conversations, doesn't feel like anything was looked at except for the idea of a zero COVID strategy, which we all know was not a reality. But moving forward, talk about how do we define vulnerable populations, Jay, and how can we, and obviously it's going to be specific to whatever whatever the thing is when this thing arrives. But what is the first thing that we need to look for in protecting the most vulnerable and also protecting the rights and liberties of the public?
So I'll answer that question first, and then maybe let me just address very briefly the how you preface the question.
Yes.
Vulnerable populations depends on the nature of the disease and the nature of the society. It's a combination of the two. And so just to give you an example, the polio virus in 1950, the vulnerable population was children. It was children that were getting paralyzed by polio. And so the public health response to that was to prioritize the development of a vaccine and then testing of the vaccine and then deployment of the vaccine in children. When there were local outbreaks, schools would close, which were an entirely sensible thing to do when the most vulnerable population is children. The issue here was the most vulnerable population was very clearly older adults. For every 7 years of age, the infection fatality rate doubles. And it was also very clear that we were going to harm children by closing schools. This is what led the Swedish health authorities, for instance, to not close schools for anyone under the age of 16 for the entire pandemic. Never. This is another point of complete agreement with Matt. That definition that the World Health Organization has for health is a beautiful definition. It's not just infection control. Avoidance of infection is not synonymous with health. It is a much broader idea, and public health is animated by that. That's what I thought public health ought to have been about during the pandemic, and unfortunately it wasn't. Now let me just very quickly address why I think we didn't have the discussion we ought to have had. And I think that as much as I love Dr. Collins, the national health, the people that were at the top of public health in the nation decided that they had access to the truth. And they decided that anyone that criticized them there's something wrong with them. There's something there. And Francis wrote a email to Tony Fauci 4 days after we wrote the Great Barrington Declaration, calling me a fringe epidemiologist and calling for a devastating takedown. That froze the conversation. I mean, of course, the spirit of that goes even before that. The scientists would write to me saying, "Thank you for speaking up, Jay. I can't do it because I'm afraid for my career." You cannot have a conversation in an environment where a small group of people with with that kind of power exercise it over the entire scientific community and expect the scientific community to be able to speak.
Amen.
It definitely goes back to that course correction thing. If people are afraid to speak out, that's why Brave Angels is so important, right? Freely, fully, without fear. We've got to be able to speak our minds and do so.
Can I ask a follow-up question? Because I agree. There is a balance point, but as a I was on the hook for communicating to our public about what was happening, and we at Board of Supervisors meetings, I would stand up and offer the report, and it's a public democratic process, and for a good almost 2 years, there's a long line of folks who are ad hominem, like a lot of personal stuff, threats, all that, but also, frankly, wrong, like in really damaging ways, like that the microchips are in the vaccine. I mean, like stuff where it's frank misinformation that I worry, and just this is my sense, from a public psychology standpoint, that that platform for those ideas might be harming, just as ideas might be harming. So you say, okay, if that's true, then you get into the space of like, how do we control information, right? And that is a tricky question, right? And I think part of this conversation needs to be recognizing that we have different valuation of where we toggle on there, from like total freedom of information. And we made, and I would say there was, in your case, erring on the side of controlling what was probably misunderstood or misattributed as damaging information in its nature, rather than good faith questioning of strategy, right? And that's how we should have approached it. But I think we need to be careful not to say that there is no role for public health leadership to attempt to sort of manage the world of misinformation And I don't think we've figured that out yet. And I'd love to hear your thoughts on like how would you approach like different between what you say about Great Barrington and someone, saying something that is frankly just misleading and harmful.
5D7.
I mean, that's a great question, and I think the central thing is it's the American First Amendment is the answer to that question, right? I think if you want people to trust you, you have to be open to criticism, and you have to respond in trustworthy ways to that criticism. Public health in Sweden was tremendously criticized and openly criticized, and people trusted public health in Sweden because of that criticism. And if you want to be able to counter bad information, you need to be trustworthy enough so that people believe you when you counter bad information. The problem during the pandemic was that public health would say things that was patently untrue. There's no immunity after you get COVID. There's that the vaccine stops you from getting and spreading COVID. That closing schools is not all that harmful to children. Right? That masks mandates can stop the spread if we all just comply. And people could see with their own eyes that wasn't true. And when public health officials were saying it, it made people distrust public health. And then when there's actual misinformation out there that public health wants to counter, no one trusts public health. The key is communication, open, honest communication, admission of error when you get it wrong, and then you build trust, and then you have a powerful platform to say, no, there's no magnets or whatever it is in the vaccine, right? That's not true. I think that's the instinct to control, to censor people that disagree with you, that is the root of why we have distrust in public health in this country.
Absolutely. Absolutely. No, I think that's absolutely right. I think that's where the trust actually started to break down. So now for a few minutes, do you, to Jay and Matt, I know you just asked him a question, but do you have anything that you would like to ask Dr. Jay Bhattacharya? Or Dr. Jay Bhattacharya, do you have anything you'd like to ask Matt Willis? We'll do that for a couple minutes, and then we'll turn it over to the audience to start asking a few questions.
So Matt, if I may, because I'm also a Bay Area resident, I would love to know because there were some Slack channel conversations that were publicly released by the San Jose Mercury News of the Bay Area public health officials talking to each other early in the pandemic. I would love to know what your thoughts are about internally within the public health director community. How hard was it to communicate disagreement? Was it frustrating to you? I'm not talking about with the public. I mean internally. What kind of challenges? Because I know my local public health officer, a friend of mine for 30 years, she faced death threats. Her family faced death threats, and I was heartbroken because sometimes they would cite my ideas as a reason to do the death threats. And these are, I felt for their family. I felt I did, and at the same time, my family was facing death threats because of devastating takedowns. I would love to know what personal challenges you faced and how you managed that, and was it common, those kinds of experiences, were they common among public health officers? Because it really does color things, I think.
Yeah, I mean, I was just reviewing those. So this was we basically established across the Bay Area, like what we thought was going to be, a private communication channel through Slack. And then, a year later, so there was a Freedom of Information Act and it became open. And I actually welcomed that because I think it actually painted the picture of physicians who were expert in their field, who were trying to manage something that was intrinsically uncertainty and confusing, and asking one another for advice and offering support also. I mean, a lot of us were under a lot of stress, under death threats as well. So that network, the answer to the question around being part of that network, it was extremely valuable actually to be part of a network of thought partners rather than being independent. And I think that was one of the strengths of the Bay Area. What you also saw, to your point about looking at the same data and coming to different conclusions, was we didn't always agree, right? And you started seeing, okay, Sarah's always going to be more restrictive, Scott's always going to be less restrictive, Matt's going to be somewhere in the middle. Like there was kind of this sense. And I think what was most valuable to me was really kind of the ability to recognize that the region was a single human ecosystem So we needed to know what was happening in other jurisdictions, and then how were we responding to that in a way that was sensible for the region as a whole, rather than Marin County. You know, you can gather 100 people together, and in Santa Clara, you can gather 50 people together. And there was a lot of confusing differences, which also undermined public health. So that was an important network. Is that your question? Am I answering your question?
It's just, it was interesting to read that Slack channel, to see that internal disagreement. And it was resolved by policy differences across the counties that were, for the public, was very confusing, actually.
Yeah.
And maybe if those Slack channels had been open from the beginning, if you had that conversation out in public rather than in private, maybe people could have understood better.
Right. Well, and we did have those conversations in public, and I think, you know, that's something that I think when we think about what to do next time, that's to me like the singular, like the most important thing that I did right. We did a lot of things wrong, but was really setting the table for those conversations. I mean, that thing I'm saying on Slack is the exact same thing I'm saying to our industry advisors, to our community response teams, to our board of supervisors. Because there was nothing, in fact, there was no reason to pretend we didn't know what we didn't know. And I think that was actually more the tone than people give us credit for, at least at the local level.
Yeah, I mean, because the contrast with the national level couldn't be more stark, right? You can't get the NIH to still release unredacted FOIAs of basic emails that the public deserves to know. It looks like they're hiding, still, to this day. Censorship efforts continue to this day, and started from the beginning of the pandemic. And it's still quite difficult at the national level for the public to know what exactly happened because of that. And it completely undermines trust.
A great contributor to the distrust. Matt, you have a question for Dr. Bhattacharya?
I guess one question when I saw the Great Barrington Declaration, October 2020, we were just like in the trenches doing the work. I didn't even pay that much attention. There was so much just rhetoric and iconoclastic stuff happening out there. And, when I did look at it, I thought, this is not that radical. Like, we're doing this, right? And it's surprising to me that it sort of took off in the way that it did, as sort of this piece of divisiveness. Because in October 2020, Marin County schools were open, right? The majority of our schools were open. We had established a team that was dedicated exclusively to protecting older residents, going out to skilled nursing facilities, making sure that infection control practices were in place. So we recognized that children were at lower risk, older residents were at higher risk. We needed special strategies to protect older residents. And there was that sort of continuum that we need to be focusing on. So my question is, was it your perception that was, that we weren't we weren't already focusing our efforts on what we knew to be the most vulnerable older residents? Because it reads that way. And I'd like to hear kind of what added value that particular piece had in your mind.
I mean, I completely agree with you in one sense. The declaration was based on ideas that were old as the hills. For a century of respiratory virus pandemics, we followed the declaration, even a century before we wrote it. The idea of identifying the most vulnerable, being cognizant that very restrictive measures are going to cause more public health harm than good. Those were normal principles in public health. Don't panic, people. So in that sense, I agree with you that the declaration was nothing new. The reason why it was that we wrote it was because it was not being followed by public health. My kids were out of school in Santa Clara County for a year and a half. In Uganda, kids were out of school for 2 years. 4.5 million kids in Uganda never came back to school after 2 years out of school. Many of them, it turns out, were because they were sold into sexual slavery or put into child labor because of the economic harm done by the lockdowns. It was a document aimed at the world. We got translations from 40 different countries where people just offered them to us for free. Just in response to reading it, there was in locality after locality after locality, there was a huge focus on suppression of transmission and inadequate focus on protection of vulnerable people. It was, I mean, that's why we wrote it. I mean, there's no reason for me to write such a document if I thought that we were already doing it. I think even in California, we ended up, at the time, it was like 40% of the deaths were among people over the age of 65. Or not actually 40%, 80% of deaths were people over the age of 65, 40% in nursing homes of the deaths. So it seemed to us that there wasn't an adequate focus on, just to give you some sense of why this was important, right? In country after country, including the United States, including even in California, COVID-infected patients were sent into nursing homes very early in the pandemic. Now, why did that happen? It's not because people were bad or evil. It happened because the goal was suppression of the virus, keeping hospital beds open. If the goal had been protection of vulnerable older people, no one would ever have thought to do that. The goal decided the strategy, and it was clear to us that the goal was incorrect. The goal could not be suppression because we didn't have a technology to suppress it without causing tremendous harm. If we changed the goal, I thought we could have better results for older vulnerable people and also for younger people who were facing tremendous depression, anxiety, as a result of the policies that were followed.
Thank you. I do agree with many of the principles in the Great Barrington Declaration. I think if we're talking about how to do this better the next time, in my experience as a local public health officer, it is the devil is in the details, right? Because it's like you either do or you don't do something, right? You either open schools or you don't, right? And these are and to have sort of vague guidance that is then getting its own sort of political force behind it was actually a challenge, right? Because we, like the skilled nursing facility question, it's just an example of like when you have a local experience, how that nuance is so important. We had to face that question too. Like basically, Dr. Willis, are you gonna allow us to discharge patients to SNFs who have COVID-19? No, bad idea, right? That makes sense. Here's the problem. The next statement is, we've got people in gurneys in the ER waiting to go upstairs, and we've got grandma who's well, she's still positive, but she's well, she doesn't need a hospital bed. She could be managed elsewhere. She's taking a bed from someone that needs to go upstairs for that level of care. Dr. Willis, will you have people, and suddenly it's a different question. So I think that's just one example of hundreds where it's sort of easy to have sort of a distant, almost like philosophical idea of how we should approach it. But it really needs to be answered in the context of the tools and resources and values that you have available to you at the local level in real time. And that's the conversation that I think we needed to have. And that's where I would have, I think, invited you, right, into those kinds of conversations. Like what you're saying makes sense. How do you actually do that?
And so that was exactly what we intended. We intended, because very clearly in the slums of Mumbai, you're going to have a very different policy for how to protect the vulnerable than in Marin County, right? The resources are different, the living situations of people are different. It required the ingenuity of folks like you, Matt, to say, okay, here's how my people in my community are living, here's the resources we have, how can we deploy them? And 3 fringe epidemiologists cannot possibly write the plan for the entire world. We wanted to have a conversation within local public health for how to best deploy them, but with a strategy focused on protection of vulnerable, not suppression, disease suppression, which was not possible. And so that was the reason for writing it. We were expecting there to be, when we wrote it, a tremendous outpouring of like, let's think how better to protect vulnerable people. That's what we wanted, those local, I would give talk after talk where I would say, look, I want the local conversations, just like you said, to happen. But instead what we were met with was vilification. Yeah. And those conversations as a result didn't happen. And it was heartbreaking to watch. I mean, both for me personally, to face the kind of vilification was hard. But more to the point, so many vulnerable people were hurt by the policies failing them. And so many less vulnerable people to the disease were hurt by the policies that were, like the school closures. I think almost everybody now agrees were a tremendous mistake. So it would have been much better had we had an open conversation, which that was the purpose of the Great Barrington Declaration.
conversation needed to happen. All right, let's open it up to. Wow. Let's start with the pink beret right over here.
My name is Debbie Silverman from Cincinnati. I'm a purple wearing a blue band. I'm a recovering allopath, which means a conventional physician who got sick of sick care. And I got into holistic and functional medicine. You touched on it, Dr. Bhattacharya. One of the biggest issues preventing conversation and dialogue was the censorship and suppression. I get over a dozen holistic newsletters. People like Peter McCullough, Merrill Nass, Sherry Tenpenny, David Brownstein, who are on the front lines doing the research for saving people with ivermectin and hydroxychloroquine, and those studies were suppressed. There were webinars that were international. I got data from Brazil, and they were saving lives by giving people ivermectin early to keep them out of the hospital. And a separate whole issue is the whole vaccine. And they suppressed medications that were safe, effective, and approved by the World Health Organization in order to get the emergency use authorization for the vaccine. And that's another whole discussion that they're still pushing and preparing us for the next pandemic, which is probably going to be the bird flu. I could talk for hours.
I think many of those folks, they face tremendous, that you named on that list of folks, face tremendous vilification because they had their ideas. I don't necessarily agree with all of their ideas, but they shouldn't have been treated that way. I think the way that you learn how to manage a new disease is by listening to people who are managing patients, and then you form hypotheses, you test them more rigorously, and then you learn. If you tell people that are managing patients for a new disease that no one knows how to manage it, oh, you're obviously wrong, before the studies have been done to show that they're obviously wrong, and then you fire them, which several of those folks you on that list actually had happened to them, you're going to get very bad results, and it's unfortunate that's what happened. I mean, again, not to say that I agree with everything that they thought, but they were acting in good faith, trying to come up with ideas, and we should have listened to them.
Who's behind the censorship? Is it the media or is the government suppressing the media? Unless the public gets that information.
It's the government. The U.S. government played a central role in the censorship efforts.
Okay, let's get another question. Let's go to Travis, and then we'll do the next one over here. Can you hear me right?
Yes.
Well, first off, Dr. Willis, thank you so much for joining us. We've been trying to have this conversation with both sides at Braver Angels for so long, and you showing up, just thank you for doing that. I want to preface this conversation, this question, it's for you, Dr. Bhattacharya, by saying that I truly do view the bravery that you showed during the pandemic as one of the most incredible things that's helped this country and will help this country heal. So that's the framework for the question. And so my question is, in terms of having a conversation with the other side, particularly with somebody like a Dr. Francis Collins, do you think, and maybe if there is anything, do you think that you've done anything to maybe disencourage that conversation and disincentivize the other side from engaging in it? And could you maybe be a little introspective for us and say, would you do some things different to encourage that going forward?
I mean, I was asked very early in the pandemic why I was contradicting Dr. Fauci. It was like an interview in April 2020. I said, I'm not contradicting him. I just don't know the answer, and I don't think if anyone knows the answer. And in science, we don't obey authority. We try to formulate hypotheses, we get data, and we try to come to conclusions, right? So, Dr. Collins, I've admired him for decades. He's a great scientist, a great man. He's a Christian as I am. A man of great bravery to write a book about his faith in the middle of a field that doesn't treat that very well. I've always admired that, and will always admire that about him. When I first learned that about that email that he sent, I was absolutely devastated, because a man I respect, I lost a lot of respect for. I've tried very hard in my dealings with other people to be forgiving. I mean, it's part of my spiritual discipline. I don't know if I've been perfect at that, and I've tried to, at least in my heart, forgive him. The common friends of mine that have reached out to him to have a conversation in private with me, and he's turned it down every time. I've said yes every time. I don't know what more to do about that. I think the explanation that my common friends have given me is that he is upset that, the lawyers, the White House lawyers are telling him that because I'm a plaintiff in that Missouri versus Biden censorship case, where the whole Biden administration is the defendant, that's the reason why. And it just breaks my heart that would be a reason. I mean, the purpose of the case is to get rid of censorship. And if he's using that as a reason to not speak with me, essentially to censor that conversation, I mean, it's just to talk about the irony, right? I don't know what more to do. I wish he would speak with me.
We'll continue to work on that.
We'll continue. Blue,
I can't see your name. There we go. Bob. Thanks, Bob.
Yeah, Bob Lawrence. As you both have sort of suggested, that getting accurate information about the science out publicly in a timely manner was one of the great challenges that we faced in this past pandemic. I want you both to sort of imagine that you are leading the federal response to the next pandemic, and it's a serious, deadly disease, and there is a study that you know to be deeply flawed, that's making the rounds out there. It's being promoted by a handful of academics, and you know that it's getting great traction, people are acting on that information, and you know that if they act on that information, it's going to put their lives at risk. So as the pandemic czar, if you will, how would each of you respond? Because I agree, censorship is not the way to deal with it, but then misinformation is a real challenge, and it can kill people.
Yeah, thank you, Bob. Why don't you start off with that one, Matt?
Yeah, thank you for that question. I think, first of all, we need to think about the environment that question lands in. And I think when we're talking about opportunities for doing things better, if I was the czar, I would have tried to set a more clear research agenda up front, where, if you have the CDC available to you, the NIH, there were opportunities to design studies that would have relieved some of the ambiguities that we ended up facing at the local level in terms of decision making. So you might actually have a lot more clarity for everyone right off the bat, right? It is into that environment that, nature abhors a vacuum kind of thing, right? That environment of lack of clarity invites rogue voices, right? And then the question is, how do you manage them? I think I would, and then we had some version of this, obviously. What I would do is also, I think, have created an environment where we recognize that there's going to be just an overwhelming amount of information coming at us, right? And that we need to metabolize it together as a community, right? And if you can establish yourself as the czar, as someone who is reasonable, is trustworthy, is open to ideas, you can navigate through the benefits and harms of that approach, right? Where you can actually have a more collective understanding of what that represents. What does not work is just saying, don't look at that. Like, no one look at that. Because then people start to worry what you're actually pushing. Yeah, exactly. It invites even more regard. And I actually think that's going to be a feature of the next pandemic. Like, no matter what we do, I think it's back on. Whether it's climate change, I think that's going to be a feature of any of the emerging threats, is going to be this sort of heterogeneity of information. And the only way I think we can manage that is to open the tent wider rather than close it down.
Good.
I 100% agree with that, but let me just, I think you mentioned in one other additional step, and the question is, how, if I were Francis Collins, if I were the head of the NIH, would I have dealt with troublesome people like me?
You said that.
And what I would have done is I would have convened a public panel and had a conversation in public.
Yeah.
That's what I would have done. I think that.
Very nice.
Amen.
Very nice.
Let's go with white jacket and Lanyard back here.
How's it going, gentlemen? So I promise I'm not going to give you my whole backstory, but it's a tiny bit relevant. So, thank you. So if I were to have attended this convention before 2020, I would have had a blue lanyard on. And the reason that I don't is because of COVID. So I think that that's important, and I know a lot of people for whom that is the same thing. I'm currently the finance chairman in the New York Republican Club, so if that tells you the crossover that I did. So my question for you guys is kind of twofold. One, so I actually never really minded that advice was coming out of the public health establishment, whether I thought it was right or wrong. That was not so much of a concern to me, so long as the solutions that were being proposed were going to be voluntary, right? Because then I can sit there and I can decide, well, I think that this is good information, I think this is not good information, I can do this, I can do that. So my sort of broad question, and forgive me, I know you're both in public health field and not in government, but, is regardless of what the advice is that's coming out of the public health establishment, do you think that there's ever a place for mandates, particularly when they are coming out of executives like governors that have declared states of emergency without any input from any state legislatures? So do you think that there is ever a place for that? Obviously, like, no secret, my answer is no, but I would love to hear what you guys have to say. And secondly, somewhat related to that, because there's been a lot of conversation about NIH and the World Health Organization, and a lot of conversation about how responses need to be different locally, do you think that there is a place to sort of decentralize a lot of these health conversations and bring it back to communities? Again, no secret, my opinion is that the WHO should be dissolved. My opinion is that the NIH should have a very limited role in, if any. I think that it should be decentralized, but I'm curious as to what you guys think. Apologies for the long-winded question.
Matt?
I think my answer is yes. I do think there still is a role for mandates in certain situations. And I think if we just think about, right, this is a fundamental just question about democracy, right? Like congressional, like we value freedom in the United States, right? And it's in it's in the sort of the documents that found this nation. Across religion, travel, all that, up until your behavior affects the public, right? So right off the bat, you already have an a priori understanding that there's a point where we don't let people drive 150 miles an hour down the highway, right? You might want to do that, but you're not allowed to do that. Why are you not allowed to do that? Because you could kill someone, right? So we already, it's all of our, this is essentially what law is based on, right? So we already have an understanding that there is a point at which you will deprive someone of a freedom we otherwise value for the sake of the greater good. And that's the conversation that needs to happen specifically. And when it comes to communicable diseases, that conversation needs to happen on a very clear understanding of what that corresponding risk is, right? And that's, I think, what we ended up with was a very cautious early approach because we didn't actually know what the risk was for people. And as we started learning, as Jay is saying, that the mortality rate was lower, that there was probably much more asymptomatic infection than we realized, those mandates were lifted, right? At least most of us did everything we could to lift freedoms as quickly as possible. So I do think there is a role, but it needs to be exercised incredibly judiciously. And then to the question of decentralization, Absolutely. I mean, I think that was, for me as a local health officer, having to make decisions, living in the community where I'm actually practicing public health and making policies, it was necessary for me to be a convener of conversations across sectors to better understand how the implications of our policies would affect people. And I have countless examples of how I might have taken one approach and instead, having gotten that feedback, chose a different approach. So yes, but I also believe that there needs to be some top-down, right? It's top-down and bottom-up.
So I weirdly agree with Matt on this, which is maybe surprises you. I think that the thing is the extent of evidence you need before you impose the restriction on freedom, right? So you have some patient with Ebola that wants to wander around the community. I completely agree that the public health authorities ought to be able to quarantine that patient until he's better. Because there's tremendous evidence that Ebola spreads by contact with bodily fluids and so on, and so and if someone was walking around the community, they could spread the disease that would otherwise harm a lot of people. Scientific evidence is abundantly clear on that. When the mandates are imposed in the face of scientific uncertainty, that's when I start to become much more iffy, and especially when they're imposed in the face of overwhelming scientific evidence to the contrary. Let me give you an example of that, and that is the vaccine mandates. Right? You had a vaccine here that it became very clear early on in 2021 that they did not stop you from getting and spreading COVID. The COVID vaccine trials did not test to check whether they stop you from getting and spreading COVID, the 2020 trials. On the basis of that, you cannot mandate them. Right? The argument for mandating is just as Matt said, is my health decisions affect you. Well, we don't know that it affects you. We don't know that because we don't have the scientific evidence for that. The threshold must be tremendously high because the value of freedom in public health is also tremendously important. And I think that is the problem that we had, is that people forgot that in public health. Decentralization, there's a role for the NIH. It should be doing studies that inform local public health.
Very good, very good. Leslie, let's get,
Okay. First, thank you both for being here. Oh, okay, so I have one factual question and then one sort of more philosophical question. I'm realizing that I don't know now, many years down the road, what the death rate is actually believed to be from the pandemic, or from SARS-CoV-2. So that's question one. The other is, okay, so we're now facing this potential, probably not a possible pandemic of H5N1. And there is some evidence that's been transmitted from animals to humans. There's very little mandated testing at all of farm workers where it's, livestock workers where it's been found. There's been no regulation of raw milk in a lot of circumstances where a lot of virus has been found. I'm a fan of the David Kahneman School of Research because you get two people who disagree, and you ask them to figure out what kind of research they would need to do to answer their disagreement, to resolve their disagreement. So I would like to know where you think the CDC, the NIH, local public health, anyone should go in terms of looking ahead to this possible pandemic. Should it be managed? Should there be regulations? Should there be something? Where do we need to go?
go ahead.
Why don't I take the first question and Matt can take the second? The infection fatality, it's wrong to ask for COVID, what is the infection fatality rate? Because it varies tremendously from person to person, depending on your own individual circumstance. The most important predictor is age. Body weight matters, diabetes matters, a few other things matter. So for instance, in Africa, the seroprevalence study suggests that the COVID infection fatality rate was something like 0.05%, 5 out of 10,000, for a population that had never had COVID. If you have had COVID and recovered, or if you've had some version of the vaccine, then the infection fatality rate goes even much lower than that, factor 10 you can convince me more and lower. So the infection fatality rate now is a fraction of what it was in 2020, largely because of immunity. So the average infection fatality rate we found in Santa Clara County, not in the nursing homes because we weren't allowed into the nursing homes, was 2 out of 1,000 in April of 2020. The median in the world of infection fatality rate studies, it's based on seroprevalence studies in 2020, found that it was 0.27 out of a percent, which is 2 to 3 out of 1,000. In New York City, it was higher, maybe 8, 9 out of 1,000. In places that were older, it tended to be higher. In places that were younger, it tended to be lower.
Hard question to answer.
Yeah, and that, you know, low infection fatality rate really compared to some other, like Ebola or other, but, you know, when everyone's infected, it's still 1.2 million deaths, right? So that's the other side of it in the United States. So my answer to the H5N1 is, I mean, I like to think about this as like, what if we knew that SARS-CoV-2 was sort of on the way, like, you know, a year earlier, where we would be? And we're in a knowledge acquisition phase right now. My sense of what H5N1 is that we need to be doing everything we can to understand what it is intrinsically, what is the risk for human, you know, person-to-person infection. What are the clinical associate, like what is the pathology? What is the level of severity of H5N1? Where is it being transmitted? I mean, this is really right now classic descriptive epidemiology. And we don't go too crazy at all in any conversations about regulations until we have a better understanding of what this bug actually does and how it behaves. And I think we are already missing opportunities, even now, in that space. We're not testing. I mean, the surveillance system is not, it's a little patchworky and hodgepodge. And, you know, raw milk is sort of a clear potential source. You know, it's good because of the tropism for mammary tissue and the fact that it's not pasteurized. Raw milk is on the shelves in Marin County, California, right? I'm not going to say people can't drink raw milk. I'm going to tell them it's probably not a good idea because it isn't. but you know, it's on that question around freedoms. I'm not going to say we got to pull the raw milk off the shelves until I have a better understanding of the risk that would represent, right? And if I start seeing that A, we're seeing live virus in raw milk, and B, we're seeing people who are made sick from it, that might be a point where we start to actually try to influence the marketplace of the availability of raw milk.
If you don't mandate that, and if you don't insist that people get tested and look at tested.
Right, and so we are now engaged just this week for the first time, because it wasn't happening elsewhere, of just testing raw milk. Yeah, really purchasing it off the shelves and testing it, and we haven't seen any H5N1 yet. So that's the kind of I think common sense thing we need to be doing at this stage.
Absolutely. Let's get Angel. He's right there.
Hey everybody, I have 3 questions. The first one's in 2 parts.
I think we're going to go
So you talked a little bit about trust, and you talked a lot about what we should have done, what should have happened, the better way that it could have happened. Looking forward, my question is, what can I think it's pretty clear that we need authorities and governing bodies and institutions that we can trust to do this work, because it can get pretty chaotic if everyone's trying to figure it out on Twitter, right? For themselves. So how can these, moving forward, what's something concrete that these institutions and governing bodies can do to regain our trust? And what's something concrete that we can do to be more trusting of them in the process? So kind of in both directions.
Perfect.
I mean, I think the public health response in the United States to COVID was a catastrophe. And I mean, I think literally everyone agrees on that. So the question is, how do you regain trust? The very first thing is that the bodies and the leaders that led the pandemic response need to admit that. We need to have an honest, like when there's a plane crashes, we have a inquiry into what caused the plane to crash. I think the spirit of that inquiry should be not a pointing fingers necessarily, because that's usually not that productive. It should be what went wrong. Let's go look in the black box and then make reforms. It's hard though, because I've been advocating for that for now 3 years, and I think we're not anywhere near close to that. And until that happens, I don't see how the American public can trust public health again. As far as like, what should the public do to be more trusting? Don't. Look, our job in public health is to earn your trust, not for you to give it to us. We work for you. You don't serve us.
Yeah, I just, I do think there's sort of a rhetorical thread there that isn't that helpful in my world, because the answer can't be not, like just don't, like just apologize. We need practical solutions. I'm sitting in a county of 260,000 people, 3 hospitals, 100 schools, and we got decisions to make. And it doesn't help me just to be like, well, they screwed it up. They need to admit it. I want to know what to do now, right? Because I still have people to take care of. And that's, I think, the difference between where you might sit and where I sit. And so there are some structures, actually. One is community resiliency teams or community response teams, CRTs. We need to establish those in every community, right?
I might come up with another acronym that one's pretty comfortable.
Right? Response? I mean, community response. Yeah. It was a community response team work?
CRT.
Oh. You're right. Sorry, you're right. We'll have to come up. Yeah, health equity zones we started calling them. But the point, the structure of them is basically to have community-based leadership, convene conversations with faith-based leaders, with schools, with law enforcement, with elected leaders, and you're having a forum where, and we met with them every single week in Marin County. We established them, 4 of them across the county, because we had 4 distinct different communities, both geographically and culturally, that we needed to reach. So any given strategy, the next vaccine rolls along. The question for Senator Fell is, how should we best implement this to greatest benefit in this community? And is public health reaching out for partnership, right? And that's, to me, can be replicated at the national level. You got the NAACP, you've got AARP, you have representation of different groups at the national level that you could have public health actually convening conversations, setting the table for anything that's coming along that's relevant, where it might be a policy decision at the end of it, to have those conversations about how does this read for you? And it's bi-directional. It's bi-directional dialogue and iterative and flexible. So that's a structural thing. I think the solutions need to be structural. There's a lot of rhetoric around it, but we need actual structure. So one is community resiliency teams, and the other is industry advisors. That's the other thing we did locally, was to have advisors from all across the different industries economically participate in those conversations. And it's really just a matter of sitting down and hearing different perspectives.
Final question, let's go to Suzanne, and then if anybody else, well, we're right at the end of our time, so Suzanne, quick, and then
First of all,
anybody needs to
thank you
leave.
both for coming and for this incredible conversation. It's been great to be able to hear such sound reasoning. And I'm curious why there isn't more emphasis on the prevention aspect. Vitamin D, health, metabolism, having people, the very thing we know that was really helpful with viruses is being out in the fresh air and sunshine. Closing down the beaches was not, was totally contrary to that. Having people viewing each other as disease vectors, jumping across the street and locking down. How do we do that better? How do we have people focus on the things that they can take control over to this woman's going to start threatening about the early treatments. There was so much evidence coming out about effective early treatments, and then it was disappearing from, I would read a study, it would be gone. And I was like, how is it possible that when we really needed that help, that they were making that evidence disappear? And was it simply a way to make sure that they could have a claim for emergency use authorization for the upcoming vaccines, which were a very profitable thing as opposed to those generic early treatments that were already available? And many others, but I'll stop there.
Yeah, I think it is a piece of the larger conversation, right? Which is how wide are we able to make the frame around well-being, right? So that you can consider, I mean, the fact is that we had low mortality rates in Marin County, partly because we also are an affluent, wealthy community where there's a lot of health. People exercise, that, you know, the nutrition is a value. And vitamin supplement, I mean, there's a lot that goes into health and well-being that we need to, even from a research perspective, pull that into the frame. And I think that is a matter of, adhering to the World Health Organization definition of health, mental, social, and physical well-being. And I guess just as you were asking the question, I was reflecting on the fact that when we talk about well-being more holistically that way, I actually do think it is a public health threat not to be able to have this kind of conversation. That this is actually public health. In my definition of public health, this is public health in practice. Because those conversations are damaging to us when they're not happening in these more productive ways.
No, that's absolutely right. Final word, Jay Bhattacharya.
I mean, amen to this. I mean, absolutely. I think just a couple of quick notes in response to your question that I think are a problem that the public health needs to address. The corporate control of the regulatory bodies of public health became very evident during the pandemic. I've worked with the FDA for a decade before the pandemic with great scientists on drug and vaccine safety. And what I saw there just disheartened me. It was very, very quick to dismiss cheap treatments and with really high bars before they admitted vaccine side effects, for instance, that were clear in the data long before they admitted it. My model for that is regulatory capture, which has no place in the regulation. The other thing you said, which really struck me, is public health should never divide people, right? Public health told people essentially that your neighbor is a biohazard, primarily and merely a biohazard, and that was tremendously destructive. It poisoned family relationships. We cannot adopt that as the central idea. We're human beings, I believe, made in the image of God. If you're not religious, deserving of dignity and beyond simply the fact that we sometimes carry disease. Mm-hmm. And public health needs to act that way, not just say that we're just biohazards.
Very good. And that is going to wrap up our session today. I hope you all enjoyed it. Dr. Rockford.
Thank you.